My name is Natalie Morgan, and I am the Oncology Pharmacy Resident here at Monument Health Cancer Care Institute. And for my clinical pearl this month, I'm talking about Dostarlimab, or Jemperli. And I first heard about this new immunotherapy several months ago based on the results of a small clinical trial looking at patients with rectal cancer. So I wanted to look more into this medication, and I'll talk more about that clinical trial as well. My objectives for this presentation are to talk about the indications, mechanism, and dosing for Dostarlimab, and then look at both published clinical trials as well as those that are ongoing, and then finish by talking about safety data related to Dostarlimab. So first off, I want to give an overview of Dostarlimab. So Dostarlimab was FDA approved actually in April of 2021, and its primary or initial indication was for endometrial cancer, recurrent or advanced with mismatch repair deficiency among patients that have had progression during or after platinum-containing chemotherapy regimens. But then it also has an indication for solid tumors, again, those that are recurrent or advanced and have mismatch repair deficiency. So as I mentioned, it is one of our immune checkpoint inhibitors. It is an anti-PD-1 or programmed death receptor monoclonal antibody. So it binds to the PD-1 receptor on activated T cells and then prevents the programmed death ligands PD-L1 and PD-L2 from binding, and then helps to prevent that downregulation of the immune response. And this is just a graphic representation of the general mechanism for our immune checkpoint inhibitors. And so again, the programmed death receptor, PD-1, is found on the surface of our activated T cells, and the programmed death ligand, or PD-L1, is found on the surface of our tumor cells. And so when the ligand binds to that PD-1 receptor, we have the downregulation of the immune system, which is unwanted because it helps that tumor evade the immune system, helps promote self-tolerance, and avoids autoimmunity. So our immune checkpoint inhibitors then prevent this binding by essentially binding in its place. In terms of its pharmacokinetics and pharmacology, so Dostarlimab has a half-life of just over 23 days, does not have any official renal or hepatic dosing, but as we see with all of our immune checkpoint inhibitors, does have hold parameters for any immune-mediated nephritis or hepatitis, so generally holding until there's resolution, potentially using a corticosteroid taper as well, and then if there's a lack of response within 12 weeks with nephritis, making sure that we actually stop the immunotherapy. And similarly for hepatitis, if the liver function tests are more than 8 times the upper limit of normal, or the total bilirubin more than 3 times the upper limit of normal, permanently discontinuing the medication. So for endometrial cancer or solid tumors, it has the same dosing where it is given as an initial 500 milligrams every 3 weeks for 4 doses, and then followed by a maintenance regimen of 1,000 milligrams every 6 weeks. And it's typically continued until disease progression or unacceptable toxicity. It's given over 30 minutes as an IV infusion, and then comes in a 500 milligram single dose vial. Moving on to some of the background, wanted to talk just a little more about endometrial cancer in general, since this was the initial approval for Dostarlimab. So endometrial cancer is the most common gynecologic malignancy in developed countries, and fortunately the majority of cases are caught early where we have a curative intent for treatment. However, there has been increasing incidence as well as mortality rate with endometrial cancer. As we've been talking about immunotherapy, endometrial cancer actually does have the highest rate of mismatch repair deficiency of any tumor type, and that deficiency occurs when there's a deficiency in the mismatch repair genes that repair our mismatched DNA base pairs. And so when there's a deficiency in those genes, then that leads to an accumulation of DNA replication errors at microsatellite regions. And in endometrial cancer, the estimated rate of mismatch repair deficiency is up to 30%. As I mentioned, relatively rare to have an advanced diagnosis at presentation. So typically regional lymph node metastases in 21% of cases, and then distant metastases only in 9% of cases. But for patients that do have advanced disease, it's a difficult and not a lot of treatment options. So currently lenvatinib, which is a multi-targeted tyrosine kinase, as well as pembrolizumab, another immunotherapy, are approved in combination for recurrent or metastatic endometrial cancer. But we do see a high rate of a pretty significant adverse events, so grade 3 or higher rate of 66.9%, and then a discontinuation rate of 17.7% for one or both of these medications. So definitely a large need for additional therapy for patients with advanced endometrial cancer. And then just looking at our NCCN guidelines in terms of where dostarlimab falls. So you can see it is actually a category 1 recommendation for useful in certain circumstances, again, for mismatch repair deficient or microsatellite instability high tumors. And this was actually recently upgraded from a category 2A to a category 1 recommendation in the guidelines. So next I wanted to go into the clinical trials with endometrial cancer and dostarlimab. So the first trial, and really the largest trial we have of monotherapy with immune checkpoint inhibitors in endometrial cancer, is the GARNET trial, which was a non-randomized phase 1 clinical trial. This was a single group multi-center study. And for their study design, they had 3 different phases. So the first phase was a dose escalation study, looking at just trying to find the right dose of dostarlimab, so using weight-based dosing in part 1. And then in part 2A, they moved on to a non-weight-based fixed dose of dostarlimab, where it's given every 3 weeks for 4 doses, and then maintenance therapy every 6 weeks. So the current dosing that we have labeled indications for. And then part 2B is where they actually enrolled patients in 4 different cohorts. So cohort 1 was the mismatch repair deficiency endometrial cancer. Cohort 2 was the proficient mismatch repair endometrial cancer. And then they had a group including non-small cell lung cancer, as well as solid tumors with mismatch repair deficiency or microsatellite instability. And I really wanted to highlight the first and second cohorts because we'll be talking more about specifically those cohorts in a secondary analysis of the GARNET trial. So for primary outcomes in the GARNET trial, they looked at objective response rate, which they defined as either a complete or partial response, as well as duration of response using the RECIST criteria. For secondary outcomes, they looked at disease control rate, which they defined as either a response or stable disease that lasted at least 12 weeks, as well as progression-free survival, overall survival, and adverse events. For inclusion and exclusion criteria, they looked at adult patients with recurrent or advanced endometrial cancer who had progression during or following a platinum-based treatment regimen. However, patients could not have received more than 2 prior lines of therapy for advanced or recurrent disease. For baseline characteristics, they included 71 patients in their interim efficacy analysis, median age of 64, and then you can see majority of patients fell into the stage 1 or stage 3 at diagnosis. And then for histology, majority of patients, 70.4%, had endometrioid or type 1 histology. And this is the most common histology. It's more estrogen dependent. Type 2 was 29.6%, and this is considered typically to have a poor prognosis. Serous carcinoma is the most common histology in this subtype. So for results here, they determined that there were 30 patients with an observed response, so overall response rate of 42.3%. And then breaking that down, there was a rate of 12.7% with complete response and 29.6% with a partial response. And this was during a median follow-up of 11.2 months. So the median duration of response was actually not reached. And then the disease control rate was 57.7% with a progression-free survival of 8.1 months, and median overall survival was not reached. However, based on the Kaplan-Meier estimate, estimated survival at 12 months was 72.7%. Majority of adverse events were grade 1 or grade 2. Most commonly, these were asthenia or weakness, fatigue, diarrhea, nausea. And then in terms of grade 3 or higher, this occurred in 11.5% of patients. And anemia was actually the most common side effect here, as well as colitis and elevated liver enzymes. But they did not find that there were any deaths related to treatment. So for conclusions in this trial, then, they showed that Dostarlimab had a high overall response rate and a prolonged duration of response. Again, this was a single group study, and then using that unique dosing of the initial 4 cycles followed by maintenance therapy that we do see with some of our other immunotherapies. So next, as I mentioned, they did a follow-up analysis of 2 of those cohorts from the GARNET trial, and again looking at the patients with endometrial cancer with mismatch repair deficiency, as well as those that were proficient with mismatch repair. So again, this will be very similar to the initial GARNET trial in that they received the initial 4 cycles and then followed by maintenance therapy. So for their primary outcome, again, we see that overall response rate, duration of response, and then for secondary outcomes, they particularly looked at more of our immune-related response rate as well as disease control rate, and then duration of response, and then safety. So for inclusion here, again, similar to the GARNET trial, looking at patients that had progression during or after platinum therapy. They had to have received a maximum of 2 prior lines of therapy, had measurable disease, and then had not been treated with prior immunotherapy, PD-L1 treatment. And then they did include all histology types except sarcoma or carcinosarcoma. For our baseline characteristics here, so some of the differences that I noted, generally patients fell into the stage 1 or stage 3 at diagnosis, similar to the GARNET trial. However, looking at histology, you can see there are some differences between groups. So in the mismatch repair deficient group, there is predominantly in the endometrioid carcinoma, 65.7%, but then in the mismatch repair proficient, only 22.4%, so a higher rate of non-endometrioid or type 2 histology in the mismatch repair proficient, with the serous being 37.8%. And then in terms of prior lines of therapy, there was a higher rate of prior lines of therapy in the mismatch repair proficient. You can see 2 prior lines of therapy, 25% versus 42.9%. So for the results here, looking at that comparison between the mismatch repair deficient versus mismatch repair proficient, you can see there was some pretty dramatic differences here. So overall response rate in the mismatch repair deficient, 10.2% with complete response and 33.3% with partial response, and median time was 11.9 weeks. In comparison, in the mismatch repair proficient group, that overall response rate for a complete response was 1.9% compared to 12.2% with a partial response, and median time was 12.1 weeks to see that response. However, the median duration of response was not reached in either cohort. So 89.4% of patients in the mismatch repair deficient remained in response, and 63.6% in the mismatch repair proficient. So disease control rate 55.6% versus 34.6%. So again, that was the sum of either stable or partial response. For safety data, they did see a similar rate of adverse events between groups here. Most commonly, we see fatigue, diarrhea, and nausea. For our grade 3 and higher events, again, as we saw in the initial GARNET trial, anemia is actually the highest, and then we have ALT elevation, diarrhea, fatigue, amylase, and lipase elevation. For a rate of discontinuation of treatment, that occurred in 16 patients, or 5.5%. This was most commonly due to elevation of liver function test. And again, no deaths were attributable to Dostarlimab in this analysis. So for conclusions here, this is the largest prospective data that we have looking at a monotherapy with checkpoint inhibitors for endometrial cancer to date. And we do see that Dostarlimab has a higher activity in mismatch repair-deficient tumors, that response rate of 43.5% compared to 14.1%. However, they do note that there's a durable response with our mismatch repair-proficient tumors. So again, 34.6%, so suggesting that there is clinical benefit from Dostarlimab, even in the mismatch repair-proficient group. In terms of the safety profile, the authors discuss that it is expected and really similar between groups, and majority of adverse events were grade 1 or grade 2, with a discontinuation rate of 5.5%. And they did note that the response was seen across histologic subtypes. As we mentioned, though, there were some variability in terms of the histology types differences between groups in this study. Next, I want to move on to looking at a clinical trial with rectal cancer with Dostarlimab. And this was the initial trial that kind of caught my attention with Dostarlimab. So this was a prospective phase 2 study looking at overall response rate as well as sustained response in patients with locally advanced rectal cancer that received treatment with neoadjuvant Dostarlimab. So in this study, you can see the dosing is quite different for Dostarlimab. It was given every 3 weeks for 6 months in this study, and then followed by standard chemoradiation and surgery. However, for neoadjuvant Dostarlimab, if patients had a complete response after this treatment, then they went into an observation-only phase and did not undergo chemoradiation. So for the primary outcome here, they looked at sustained clinical complete response at 12 months after completion, or a pathological complete response after completion of Dostarlimab with or without chemoradiation, as well as an overall response to neoadjuvant Dostarlimab with or without chemoradiation. So they looked at adult patients with an ECOG performance of 0 to 1, and they had to have mismatch repair deficient, stage 2 or stage 3 rectal adenocarcinoma. They excluded patients that had received prior radiation, immunotherapy, or chemotherapy, so essentially no treatment for rectal cancer, as well as patients with any active autoimmune disease or infectious disease, or requiring immunosuppressive treatment within 7 days of randomization. I did want to point out for rectal cancer, in comparison to endometrial cancer, the rate of mismatch repair deficiency is only 5 to 10% in rectal cancer cases, and has been shown to have a poor overall response to our standard chemotherapy regimens. So here looking at our baseline characteristics, so again, majority of patients, 62% were female, median age of 54, 69% were white, and then majority 75% had an ECOG performance of 0. Majority of patients, 56%, fell into the tumor stage of T3, and then majority, 94%, did have positive nodes. So for results here, of the 16 patients that were enrolled, 12 patients completed treatment with Dostarlimab, and this is where the results were pretty astounding. So of those 12 patients, 100% of them had a clinical complete response. So they had no evidence of tumor on either imaging, endoscopy, physical exam, or biopsy. And this was among patients that had received at least 6 months of follow-up. So based on the study protocol, then no patient went on to receive chemoradiation. In terms of adverse events, this occurred in a high percentage, 75% of patients, and most commonly included rash and dermatitis, pruritus, fatigue, nausea, and thyroid dysfunction, but they did not see any adverse events of grade 3 or higher. So for conclusions here, they determined that rectal cancer with mismatch repair deficiency is highly sensitive to neoadjuvant dostarlimab, but they, of course, recognize that there's a longer follow-up needed to assess duration of response. Interestingly, the authors talked about how looking at the differences in response between rectal cancer versus colon cancer, they hypothesized that some of the difference in response may be due to changes in the gut microbiome that can affect potentially that response to immunotherapy. And then they also talk about how initial therapy may be very important for treatment considerations because of potentially the selection for more resistant phenotypes in the tumor cells based on that initial treatment that the patient has received. They also mentioned that at this point they've so far documented 4 patients in this study that have had a sustained response for over a year after completion of dostarlimab. So I wanted to talk a little bit about some ongoing trials with dostarlimab as well. And these are all in endometrial cancer. And I think the RUBY trial, which is a phase 3 trial expected to be published in 2024, will be very pivotal in terms of determining treatment. So this is looking at chemotherapy and dostarlimab versus chemotherapy alone. You can see this is for stage 3 or 4 recurrent endometrial cancer not responsive to curative treatment among patients that have received a maximum of 1 prior line of therapy. And they have to have no recurrence within 6 months of their most recent chemotherapy. So in my mind, that would mean they were platinum sensitive. The chemotherapy here will be carboplatin or paclitaxel. And then we have the Roxanne trial, which is a phase 2 and 3 trial looking at our PARP inhibitors, so niraparib, dostarlimab, or chemotherapy. It will be the initial 3 treatment arms. And then in part 2 of the trial, whichever arm was superior in part 1 will be compared to chemotherapy with doxorubicin, paclitaxel, or gemcitabine. Again, this is for recurrent or metastatic ovarian or endometrial carcinosarcoma. And then the last trial is looking at brachytherapy in combination with dostarlimab. And there is some thought that dostarlimab may act as a radiation sensitizer, so this will be an interesting trial as well. I wanted to finish by talking about some of the safety data and monitoring for dostarlimab. So in terms of particular populations such as pregnancy or lactation, very similar recommendations to all of our immune checkpoint inhibitors. For pregnancy, there is potential for fetal harm when given during pregnancy because there's immunoglobulins have been shown to cross the placenta, as well as risk for rejection of the developing fetus. So recommended to use effective contraception during treatment and then for at least 4 months after the last dose. In terms of breastfeeding, there's no data regarding the presence in breast milk, but it is not recommended to breastfeed during treatment or for at least 4 months after. And then for pediatrics, we don't have safety data in this population. For our geriatric population, we did not note there have been no noted differences in terms of safety or efficacy in comparison to younger populations. I did also want to briefly talk about immunogenicity in the presence of anti-drug antibodies as well as neutralizing antibodies. And this was looking in particular at the rate of immunogenicity from the GARNET trial. And these neutralizing antibodies and anti-drug antibodies have been shown to affect both the safety and efficacy of immunotherapy treatment. So based on that analysis of the GARNET trial, they found an incidence rate of 2.5% with the standard labeled dosing of dostarlimab. And they did find that this is a similar incidence rate in comparison to our other checkpoint inhibitors. So for example, pembrolizumab has a rate of 2.1%, durvalumab has a rate of 2.9%. with some of our exceptions would be nivolumab with the weight-based dosing of 3 milligrams per kilogram has a rate of 11.2%. And then atezolizumab has a much higher rate at 30 to 48%. But dostarlimab at 2.5% falls into line with our other available immunotherapies. In terms of general safety data, this table just breaks down the rate of the specific adverse event and then the incidence rate, as well as how it was managed and the resolution, and then if it required discontinuation of treatment. So a couple things I wanted to point out. Thyroid disorders, particularly hypothyroidism at 5.6%, was the highest incidence in terms of adverse events. You can see the majority of cases resolved with use of systemic corticosteroids. And then in general, there was a low rate of treatment discontinuation based on treatment with corticosteroids. So in summary, Dostarlimab is another immunotherapy. It's an anti-PD-1 monoclonal antibody. It is currently approved for endometrial cancer, advanced or recurrent, as well as solid tumors with mismatch repair deficiency. For endometrial cancer, we have the phase 1 GARNET trial, and then we have the RUBY trial, as I mentioned, looking at comparison with chemotherapy that is ongoing. For solid tumors, we saw a small phase 2 study with rectal cancer that showed a 100% response rate, so very interesting data there. In terms of safety data, it does appear to have comparable rate of adverse events in comparison to our other immunotherapy, but longer follow-up is certainly needed. So here are my references. Thank you so much for listening to my clinical pro.